Today we're going to be talking about behavioral problems associated with dementia. There are four main objectives to this talk. Number one, define the type and incidence of behavioral problems with the dementia patient. Number two, distinguish behavioral abnormalities from cognitive loss versus psychiatric manifestations of dementia. Number three, describe behavioral interventions for problems associated with amnesia, aphasia, apraxia, and agnosia. And number four, identify behavioral problems that can be medicated. When we're talking about behavioral problems, the first thing you need to think about are the four common factors that impact on a patient's behavior. First of all, there is the stage of dementia. Secondly, there are pre-existing medical problems. Third, there is the premorbid function. How well was the patient doing before they became demented? And fourth, there is the environment that the patient is living in. Medical problems such as angina that produce chronic pain can precipitate more behavioral problems in a patient who is otherwise medically stable. Premorbid function is important. Pre-existing psychiatric problems can sometimes cause more problems in the demented patient. Most importantly, however, you have to look at the stage of dementia. In the next slide, we see three brains: a mildly atrophic, a moderately atrophic, and a severely atrophic brain, depicting the progression of symptoms that you see in patients with dementia. Likewise, on the inferior surfaces, you see mild, moderate, and severe atrophy. This is mirrored by sometimes mild, moderate, and severe behavioral problems. In looking at a dementia patient, however, it's also important to consider environmental determinants for the behavior. What is the physical environment like? Is there sufficient lighting? Is there a lot of noise? Is there a lot of chaos? All of these things are going to contribute to fear and anxiety in the demented patient. How tightly packed in are the patients? Patients with dementia who are used to, say, living on a farm where they saw relatively few people may find living in a crowded nursing home to be anxiety-provoking. Likewise, the staff training is important in determining how well a patient is going to do in any particular environment. And finally, programmatic structure. Are there enough recreational therapists and other professionals to provide the kind of environment that will put the patient at ease? Behavioral disturbances are common in patients with dementia. As you see from this graphic that breaks it down by both male and female, it would seem as though males might have a higher rate of behavioral problems such as aggression, wandering, rage attacks, social disinhibition, and apathy and withdrawal. Likewise, these are common behavioral symptoms. And when you start looking at each one individually and then adding them up in sum, it's probable that any particular demented patient is going to have at least one of these behavioral symptoms. Let's look at some of the more common symptoms. Aggression, for instance. We see that if you look at the three stages of dementia, mild, moderate, and severe, that aggression becomes more frequent as the dementia progresses. So, for instance, while mildly demented patients have a prevalence of 8% for aggressive action, up to 25% of patients with severe dementia will demonstrate aggressive behavior. Likewise, wandering is oftentimes bothersome and disruptive, either at home or in the nursing home. We can see from the next slide that mildly demented patients have a relatively low incidence of wandering. They can generally reorient themselves. On the other hand, severely demented patients oftentimes wander, up to 27%. What are some of the common reasons that demented patients become restless? Because restlessness and irritability are common complaints in patients with dementia. The five that you must always keep in mind, the five basic symptoms that you need to always remember in a behaviorally disturbed demented patient is, first of all, number one, fear, number two, hunger, number three, fatigue, number four, frustration, and number five, pain. Fear, hunger, fatigue, frustration, and pain are common precipitants for abnormal behavior in patients with dementia. One of the things that produces fear in demented patients is psychosis. As we talked about in the mental illness segment to this series, psychosis is fairly common in patients with dementia. In this study from the British Journal, hallucinations were found to be reasonably common in patients with dementia. Auditory hallucinations occurred in 8% of males and 10% of females, while visual hallucinations occurred in 16% of males and 12% of females. Thus, both auditory and visual hallucinations are fairly common in a patient suffering from dementia. And by the way, it doesn't make any difference what type of dementia it is, whether it be vascular, alcohol, or Alzheimer's disease. Likewise, delusions, which are fixed false beliefs with no basis in fact, are quite common in patients with dementia. 35% of males and 11% of females in this particular study had any type of delusion, with a false belief of theft and suspiciousness being the more common presenting symptom. 19% of males and 6% of females thought that they were being stolen from, while 11% of males and 4% of females were just generally suspicious that something was amiss, that something bad was about to happen. Delusions are common symptoms in patients with dementia, and they cause the patient to be fearful and agitated. Likewise, misidentification of individuals is fairly common. Almost a half of males and 15% of females misidentified, with many patients misidentifying people, 27% of males, and also many patients with dementia feeling like intruders who are in their room or in their house, up to a third of males and 13% of females. So misidentification of individuals within their family or just individuals in general is a fairly common symptom in patients with Alzheimer's disease or other types of dementia. And this can lead to agitation and anxiety. Depression, likewise, is a fairly common symptom in patients with dementia, and it can also cause a patient to be restless. As we see from this graphic, if you look at demented individuals, clinicians will think that 17% of males and 25% of females demonstrate clinical evidence of depression. On the other hand, if you ask the patients, 1/3 of males and 2/3 of females feel like they are depressed. And if you ask the relatives, the caregiver, almost a half of the caregivers for males, as well as for females, feel like the patients exhibit symptoms of depression. Hallucinations, delusions, and depression can precipitate fear in an otherwise normal but demented patient. Let's look at some other symptoms amongst the five: fear, hunger, fatigue, frustration, and pain that lead to restlessness in a demented patient. First of all, let's talk a little bit about hunger, because oftentimes patients with Alzheimer's disease or other types of dementia have difficulty with eating. To begin with, let's think a little bit about what goes into consuming a meal. There are basically 5 components to eating. First of all, the cognitive ability to recognize food as food and to want to eat. Secondly, you have to have the upper extremity strength and coordination to get the food from your plate to your mouth. Third, your oral mechanisms need to be intact and coordinated sufficiently so that you can chew, you can masticate food. Next, your pharyngeal, your swallowing mechanisms need to be intact, as well as the esophageal mechanisms that get the food into the stomach and prevent reflux. When you're looking at a patient who isn't eating well, who is losing weight, you need to look at each of these 5 different components in order to determine what might be the problem. It's important to remember that eating dysfunction is common in the elderly. In this particular study looking at nursing homes, 53% of the patients were able to eat independently, but almost half, 47%, required some assistance. 1/3 of those individuals requiring assistance could get by with simply verbal redirection, as opposed to 2/3 who needed direct physical assistance in eating a meal. Thus, if you don't have enough staff in the dining hall to feed the large number of demented patients, some may leave the table hungry. When you're looking at dietary issues in patients with dementia, the 3 big things to think about are fluid, fiber, and calories. First of all, fluid. Demented patients tend to use more fluid, we think, than other individuals if they are motorically active. They forget to drink. They can't recognize the water pitcher as having consumable fluid, and they forget how to use a water fountain. Consequently, if the staff isn't constantly offering them fluid, they may become thirsty and dry, and as a result, they may be irritable. Secondly, it's important to make sure that Alzheimer patients and other individuals with dementia get enough fiber in their diet. Institutional food tends to be relatively low in fiber. This leads to obstipation and rectal impaction. And as we talked about in the delirium sequence, rectal impaction or colonic pain can lead to agitation. And thirdly, it's important to remember that Alzheimer patients require large numbers of calories. They're on the move all the time. And so consequently, a 1,400 or 1,600 calorie diet may not be sufficient for these individuals. When you're thinking about dietary services for a dementia patient and you're trying to make sure that they're getting enough food and the right type of food, it's important to remember a few things. First of all, the presentation of the food. Especially for rural individuals who are used to consuming large numbers of vegetables, the typical presentation of food to a dementia patient may seem somewhat strange. They're used to eating food on a round plate with piles of steaming vegetables. Instead, they get a tray that has little square cutouts that has nondescript piles of unidentifiable substances that may be mashed green beans or pureed beets. So consequently, the presentation of food, especially in an institutional setting, may be confusing to an elderly patient. Consistency and texture is very important. If patients have tremor, if they have motor problems, if they have severe arthritis, then it's difficult, for instance, for them to get spoonfuls of peas into their mouth. Or if they're asked to pick up a sloppy Joe, which cafeterias are prone to serve to patients, by the time they get that sandwich to their mouth, all of the semi-liquid meat may have oozed out of between the bread and onto the floor, losing considerable numbers of calories. Likewise, utensils. Milk may be given to a demented patient in a carton, but most elders never drank milk out of a carton. They drink it out of a glass. They may not know how to open the carton, or they may not have the motor skills to get it up to their mouth. Likewise, entree selection and frequency of feedings are very important. We have found that Alzheimer patients do better if they're fed frequently with lots of snacks, at least 3 times a day. We tend to not get into food fights with our patients, but rather try to keep them fed up as much as possible. Even if they're a little overweight, that's okay, because as the disease progresses, they're going to lose weight. And studies indicate that most dementia patients are chronically underweight. Likewise, don't ever forget the dining room environment. If there is a large amount of noise and chaos within your dining room, then those Alzheimer patients are going to be distracted and are not going to be able to tend to their meal and eat their food the way that you would like to. It's important also to remember that the drive for eating may change as a result of the brain damage. In this next slide, we see a coronal brain section through a normal individual in the region of the hypothalamus. In the center, you see the third ventricle. The next slide depicts that of an Alzheimer's disease patient. And you can see that the third ventricle, this space here outlined by the arrow, is markedly dilated as a result of loss of brain cells in the surrounding hypothalamic tissue. The hypothalamus is the brain region that contains the satiety center and the drive for appetite. It also has some influence on food preferences, which is why some Alzheimer patients may crave sweets when they never ate sweets before. Once again, we tend to not get into food fights with our Alzheimer patients. If the patient wants a lot of sweets and it's not clearly harmful to their health and it's the only way to get calories in them, then we'll give them a lot of sweets. Likewise, when we're thinking about those 5 reasons why patients become agitated, in addition to hunger, pain is a common reason. In this study, we see that up to 24% of patients in nursing homes have constant pain. and only 29% of patients in nursing homes are totally free from pain. That means that 1/4 of your Alzheimer patients are probably going to have constant pain. In a study that looked at the cause of this pain, we see that arm and leg pain is fairly common in patients with dementia, as well as back and joint pain. This graph also demonstrates the fact that intact patients complain of pain much more often than demented patients. Why? Because the dementia patient may not have the memory or the verbal skills necessary to explain to the treatment staff that their joints are hurting. You know, if an Alzheimer patient has angina and had it all the night before, when they may wake up in the morning because they have memory problems, they may not be able to report to you that they were experiencing angina. Likewise, if you're prescribing your medications on a PRN basis and the nurse walks up to a demented aphasic patient who doesn't understand spoken word and asks the patient if they're experiencing pain, the patient may not be able to explain that they are having pain, and as a result they may not get that pain medication that they need. This can result in agitation. All it needs, rather than Haldol, is a little Tylenol. So, we were talking again about the 5 common reasons that patients become restless: fear, hunger, fatigue. Alzheimer patients and other individuals with dementia become tired easily. They require naps in the middle of the day. In general, we don't struggle with patients. If they want to take a nap, we allow them to sleep just a little bit to help regain some of their vigor. Likewise, frustration. You have to remember that these patients oftentimes know that something is going on. They are afraid, they want to communicate with you, but they can't. So consequently, as all human beings would be, they become frustrated with their circumstances. What are some common behavioral problems amenable to behavior management? And again, this is in compliance with the OBRA guidelines. This is what the nursing home inspectors will be looking for. What are the types of behavioral problems that you expect the nursing home staff to implement some sort of behavioral management strategy for? Pacing, wandering, attempting to flee, repetitive questions, incontinence, false accusations, struggling during activities of daily living, intermittent aggression. These are best treated with behavioral interventions, and we're going to talk about them in detail in just a second. But if you've got a staff that's frustrated with the patients, what should be some of the trigger signs or the trigger words from your staff to let you know that they are misidentifying symptoms in patients and becoming frustrated? Well, you know, in the non-professional, you'll hear the staff say words like, "That patient is stubborn, he's just mean," or "she's just crazy." Of course, those of us with licenses use other more professional terms like resistant, manipulative, and passive-aggressive. But you know, it's all the same. What the staff is saying is they're frustrated and worn out with these patients, and they're attributing this to intentional behavior rather than what it actually is, which is a result of brain damage. When you hear those trigger words, be alert to the fact that your staff may be overreacting to some of the behavioral consequences of dementia. Well, let's look at some of the typical behavioral problems that you may run into, whether the patient is in a nursing home or whether the patient is being cared for by a family caregiver. Well, first of all, let's talk about the individual who asks the same question over and over. Why does the patient ask the same question? Am I going home today? Where are my glasses? That individual who's at home, who may ask their caregiver over and over again, where are my glasses? When is my son going to come visit me? What are some potential causes for this? Well, first of all, amnesia. Patients with Alzheimer's disease forget that they've asked the same question just 2 minutes ago and forget the answer that you gave them. Likewise, especially in nursing homes, some Alzheimer patients simply get bored and ask questions. And patients who have language problems, who have receptive aphasia, can't understand the answers. For the forgetful patient, recreational activities can distract them from the fact that they're worried about when their caregiver is going to visit them. Likewise, recreational activities help with those individuals who are bored. The patient who's having language problems, the best way to deal with them is through nonverbal communications. But it's important to remember, as we see in the top slide of the normal temporal lobe versus the bottom slide of a temporal lobe of a patient with Alzheimer's disease, repetitive questions come from brain injury. Here, in this area here, you see the arrow pointing to the hippocampus, where recent memory is programmed and laid down. Since their hippocampus is damaged, they can't remember the fact that you've just answered that question 2 minutes ago. What about that patient who steals? Every nursing home has that demented individual who rummages through other people's room and walks off with their belongings and then acts in a disbelieving and shocked way when it's pointed out to them that those glasses or that wallet doesn't belong to them. Well, the most common reason is disorientation. Simply the patient can't remember where their room is and what are their belongings. In which case, recreational activities to keep that patient involved in things besides rummaging are important. Sometimes the patient is delusional. They actually believe that the things that they are taking belong to them. In which case, antipsychotic medicines, a low dose of Haldol, for instance, may help in lessen that false belief. These symptoms can be very distressing, that is, stealing, and oftentimes people begin to infer that the patient is a bad person, they're dishonest. Remember, it results from brain injury. Stripping, disrobing, is a very, very distressing symptom. It can be seen either at home or in the nursing home. Why do patients take their clothes off? Well, to begin with, they may have amnesia. They may forget that you've told them to keep their clothing on. In which case, the best thing you can do is to keep their time tied up, keep them in recreational activities. They may have apraxia. They may not know what to do with their clothing anymore. In which case, you can put them in a jumpsuit and just reverse it so it buttons up the back. These jumpsuits can be bought at Kmart or any other discount store. You can cut out the neck so that it doesn't chafe on their neck. And most apraxic patients can't figure out how to get that jumpsuit off. Likewise, if they're incontinent, that ensures that they don't take off their diaper. Anxiety, the patient may simply be nervous and is looking for something to do. Likewise, recreational activities will help here. Delirious patients, and again you need to go back to our section on delirium and look at our fact sheet on delirium. Delirious, confused patients can sometimes strip off their clothing, not knowing what they're doing. And yes, boredom. Some patients can simply take off their clothing because they don't remember where they are or what they're supposed to be doing, and it seems like an acceptable thing to do. Here again, recreational activities may help alleviate some of that boredom. Remember that disrobing is very similar to the behavior that you see in your 18-month-old, because after all, dementia is development in reverse. These people are going back in time, and like your 18-month-old, taking your clothes off has no significance aside from the fact that it feels good. But you must always remember that when it comes to disrobing and other annoying behaviors, it is one of the 4 A's of Alzheimer's disease. It is a form of apraxia, and consequently it must be viewed as a form of brain injury. On the top you see a normal brain, down below you see the atrophic Alzheimer brain with parietal lobe atrophy. That's where dressing skills are programmed, leading to apraxia. Incontinence can be a very distressing symptom in patients with dementia. Most patients, as they progress into the middle stages of their disease, develop some type of incontinence. Why do Alzheimer patients become incontinent? Well, first of all, they can be disoriented. They may forget where the toilet is. So even though they know they need to go to the bathroom, they can't find it. In which case, put them on a toileting schedule. Simply take them to the toilet every 1 or 2 hours. Sit them down just like you would with your 18-month or your 2-year-old. Allow them to perform their bodily functions, and you'll find that it helps significantly with keeping them dry. Especially females may develop urinary tract infections, in which case treating the urinary tract infection will make the incontinence go away. This is particularly true in the mildly demented patient who all of a sudden, for no good reasons, develops incontinence. Some medications can cause patients to become incontinent, and you need to look in your PDR to see if that's the case. Urological problems, GU problems, can also cause people to be incontinent, especially prostatic hypertrophy in males, in which case a urology consultation may be necessary. Remember, if you can keep a patient continent for 1 or 2 extra years, you're probably saving a lot of wear and tear on both the patient and the caregiver. Delirium oftentimes has incontinence as a symptom. This is the mildly demented patient who's doing great, and now all of a sudden he's incontinent and fighting. This patient is delirious. And again, you need to look at the delirium segment for this series and look at our delirium fact sheet on ways to evaluate and manage that patient. Rectal impaction can sometimes cause a patient to be either incontinent of either urine or feces. And likewise, it's a simple procedure. Just disimpact the patient, put them on a high fiber diet, and check them in the future to make sure they don't become impacted again. Incontinence is worth evaluating in a mild to moderately demented patient because there may be some reversible causes. Incontinence is very, very frequent in severely demented patients, and in that circumstance you may want your evaluation to be more limited. Again, it's important to remember that incontinence is a result of brain injury. On the top you see a normal frontal lobe. On the bottom you see an Alzheimer's frontal lobe. Notice the severe atrophy. The frontal lobes is where functions such as social graces are stored. So consequently, the knowledge and the drive to use the bathroom, which is programmed into our brain during development, is erased by this disease. Likewise, another social skill that's taught to us early on is hygiene. Oftentimes, Alzheimer's patients begin to refuse to bathe, won't brush their teeth, won't wipe themselves after they've been to the toilet. Why is that? Are they just becoming sloppy as they grow older? No. It's a result of the brain damage, like I just showed you. What are some of the causes? Well, apraxia. Patients may forget what a shower is and how to use it. They may forget how to use their toothbrush. Remember, that's learned behavior. It's programmed in your brain. The disease can erase the program that tells you how to shave, for instance. Likewise, language problems, aphasia, can lead to struggles with hygiene. If the patient doesn't understand that you're trying to get them into the shower, or if they don't understand that you're trying to get them to the toilet, then they may struggle with you. Here, nonverbal communication may help in lessening the struggle. Or alternatively, the patient may be simply psychotic. The patient may be afraid that something bad is being done to them. They're afraid to go in the shower or the bathroom because they think they're going to be hurt. In which case, an antipsychotic medication, a low dose of a medicine like Haldol or Navane, may significantly improve their compliance with a hygiene regimen. It's important to remember, as we see in this next slide, that dementia is a progressive disease, and you see relentless death of brain cells, as depicted here in a mild, moderate, and severely atrophic brain. Consequently, expect the patients to lose functions over time. Expect the patients to be more anxious when you're asking them to do things that they basically don't know how to do anymore. What about misidentification of caregiver? This tends to be particularly distressing to the family caregiver who's provided good care, and now the patient is claiming that they're somebody else or that they're a dead relative. Well, the most common reason for this is visual agnosia. There's no treatment for this, you just have to tolerate it. Once in a while, a patient is delusional. They'll actually believe that this is somebody different, in which case an antipsychotic medication may be helpful. The only thing that we offer the caregiver, though, is the knowledge that this results from brain injury. On the top you see a normal occipital lobe where the images of faces are stored. Below you see the occipital lobe from a patient with dementia, and you can see that it is quite atrophic. All of those visual images are lost. Now remember, the patient may remember longitudinal history of the caregiver because that's stored elsewhere in the brain, but they can't remember their face anymore. One of the more distressing symptoms that patients manifest is threats, either verbal or physical. Why do patients all of a sudden become verbally or physically aggressive or assaultive? Well, there's a variety of reasons that you need to keep in mind. It may be that the patient is simply disoriented and can't remember where they are and who you are, in which case reorientation may go a long way to reassure them. Delusions. The patient may have false beliefs about who you are. They may think that you are their jailer rather than their nursing attendant, in which case antipsychotic medications may help quiet some of those delusions. Hunger. Hungry patients are hostile patients. you may notice that patients become more verbally or physically threatening prior to meals. That's a good indicator that they're hungry. One of the first things you should do with any verbally or physically intimidating patient is try feeding them. See if that does not lessen their hostility. Pain. Patients who are in pain tend to be irritable and hostile. Try giving them 2 Tylenol 4 times a day for about a week. See if that doesn't help lessen their verbal or physical threatening behavior. Aphasia. Patients may become frustrated over the fact they don't understand what you're saying to them and react in an angry way. Delirium. A patient who, for instance, seemed to be doing really well and now all of a sudden is making threats or is swinging at the staff. That patient may be delirious. And again, you need to do a delirium evaluation. Fear. Patients may not know who you are or why they are where they are, and they're afraid. Consequently, just simple reassurance may help significantly in calming that patient's fear and anxiety and lessening their hostility. Fatigue. Like small children, demented patients become tired, and when they become tired, they become irritable. In that circumstance, the best intervention is to allow them to take a 30-minute nap. Rectal impaction. Especially moderate to severely demented patients become impacted easily, and when they become impacted, they oftentimes become irritable and hostile. They should be manually checked for a rectal impaction, and if one isn't present, they need to be mechanically disimpacted. And likewise, sensory impairments can sometimes make patients swing. If they can't see what's going on around them and they can't hear what's going on, oftentimes they will become threatening just to protect themselves, in which case maximizing their vision and their hearing may help lessen their fear of their environment. It's always important to remember, though, that aggressive, hostile, impulsive behavior is usually the result of brain injury. The top section is that of a normal frontal lobe. The bottom section are frontal lobes from an Alzheimer's patient. Frontal lobe damage is common in patients with dementia, and as a result, disinhibition is fairly frequent. And one of the signs of disinhibition is aggressive or hostile behavior. What about screamers? Patients who are, quote, disruptive vocalizers. Well, first of all, screamers are common. 25% of nursing home residents scream at least 4 times per week. This behavior is more commonly associated with dementia, depression, isolation, and poor ADL function in the nursing home. And the more you socially isolate a patient, the more they scream. What are some causes of screaming? Well, fatigue. Some patients begin to scream when they're tired, in which case the intervention is let them take a nap. Some patients moan and carry on because they're in pain, but they are too aphasic to explain to you they're in pain, in which case analgesics are indicated. Hunger. Some patients become agitated and begin to holler because they're hungry. Simply offering them a snack may lower their verbal output. Fear. Patients begin to yell when they are afraid of what's going on at their environment. Reassuring them may quiet them down. Likewise, rectal impaction can cause them to become agitated and screaming, in which case disimpacting. Boredom and depression can also lead to yelling, in which case a combination of recreational activities, and in the depressed patient, antidepressants. Likewise, for the patient who is screaming as a result of psychosis, that is, that they may be seeing things that are frightening, they may be hearing frightening sounds, they may have false beliefs that scare them. Antipsychotics may provide them with some measure of relief. Sensory impairment, patients who can't hear and see well begin to cry out for help. Checking their vision and augmenting their hearing with a hearing aid may help lessen their likelihood of yelling. And some patients who never yelled before and now all of a sudden begin to scream, once again you need to think about delirium. What's the management for patients who scream all the time? Well, first of all, figure out what the cause is and treat it. If they're depressed, an antidepressant. If they're in pain, an analgesic. Don't isolate them. Don't put them in that last room on the left, right near the parking lot if you're in a nursing home. That will only cause them to yell even more. Most importantly, the staff needs to be tolerant of this kind of behavior. They have to understand that it is a result of brain injury and not an intent on the part of the patient to disrupt the unit. Disruptive, wandering, hostile patients oftentimes wind up being restrained. Restraints are a common issue in nursing homes and also at home. Many times patients are restrained because of behavioral problems. Also, many times they're restrained because of gait problems. Let's begin by looking at gait problems as they exist in the elderly. When you're looking at an unsteady patient, there's a few things that you need to think about. First of all, stability. Is the patient unsteady? Strength. Does the patient have the physical strength to keep themselves up on their extremities? And speed. Can the patient walk fast enough in order to achieve the necessary goals? For instance, in a home-dwelling elder, can they walk fast enough to get across the street before the light changes? It turns out that a significant number of elderly patients, as they grow older, lose the speed necessary to make it from one sidewalk to the other before the light changes. Likewise, patients do lose strength as they grow older. However, if they keep their physical conditioning up, there's no reason that they should lose significant amounts of strength. Instability as you grow older is oftentimes evidence of some sort of neurological or other health problem, and consequently deserves an evaluation. Gait problems are common in non-institutionalized individuals. 8 to 19% of people not in nursing homes have some problem with their gait. On the other hand, patients in nursing homes, up to 63% of those individuals have some abnormality of their gait. So if all patients with gait abnormalities were restrained, over half of nursing home residents would have to be tied up. Clearly that's not the case because many of these problems can be addressed without restraints. If you look at gait problems in females, for example, you'll see that 6% of individuals between the ages of 65 and 69 have some abnormality of their gait, while over a third over the age of 85 have gait problems. So the older you are, the more likely you are to have some problem with your gait. Restraints are fairly common in nursing homes. Who is it that orders restraints? Well, it's important to recognize that nursing homes are run by nurses. 75% of restraint orders in nursing homes are initiated by nursing staff. And in fact, studies show that 15% of physicians were unaware of orders for specific patients. So in some instances, restraints are ordered without even the knowledge of the doctor, although the doctor does assume full legal responsibility for that restraint order. We know that at any point in time, 30 to 50% of nursing home residents are going to have been restrained. And on medical inpatient units, 8 to 17% of patients will be restrained over the age of 65. Restraints are common. The good news, though, is that since the implementation of OBRA, the overall rate of restraints in nursing homes has been falling. That is, over the last 5 years. When you're looking at a patient and trying to decide whether or not he ought to be restrained, they fall into 3 general categories. Patients for whom the restraints are indicated, patients for whom it may be situational, and patients in whom it is contraindicated. You shouldn't restrain them. Let's begin by looking at indications for restraints. Patients who need medical therapy, IVs, endotracheal tubes, who are confused and are pulling those tubes out, can be restrained to assure that they get the adequate medical intervention. If a patient is temporarily confused, let's say he's just immediately post-operative, and you don't want him to fall or injure himself, then restraining them is acceptable. In a rare instance, a competent patient may ask that, for instance, a lap buddy or a jerry chair be used in order to keep them in the upright posture. In that circumstance, then a restraint may be acceptable, but it has to be carefully documented in the medical record. Restraints are not indicated to prevent falls in an ambulatory patient. Why? Because the studies clearly indicate that patients who are restrained fall more often in the long run than patients who are not restrained. Restraints do not prevent falls in the long term, especially in demented patients. It is absolutely not indicated to restrain patients to manage annoying or destructive behaviors. That wandering, rummaging patient or that repetitive question asker cannot be restrained in order to prevent them from being disruptive on the unit. And it is not allowable to restrain a patient at the request of the family unless there is some other overriding medical or psychiatric indication for those restraints. Many patients, however, fall into a situational position where perhaps it's indicated and perhaps it's not. Hostile or aggressive behavior, sometimes you just have to restrain the patient while they are being medicated or while the problem is being addressed that precipitates the hostile or aggressive behavior. Likewise, some patients do need to be restrained to prevent falls in whom we're sure they're never going to be able to walk again. Let me give you an example. As patients progress in dementia, they begin to forget how to walk. And even though they retain the motor skills to move their legs, they don't know what to do with those legs anymore. These patients will never walk again, but they do have the ability to swing their leg over the bed rail to fall out of bed, resulting in fractures. In patients in whom these kinds of conditions have been clearly documented in the medical record, and for whom other interventions have been tried and failed, then restraining them is an acceptable way to prevent them from further injuring themselves. What are some of the methodologies that you should use if you're going to restrain a patient? Well, first of all, establish a target symptom. You need to know why you are restraining the patient. Next, you need to define the criteria for release. If the patient seems to get more confused in the early afternoon or the evening and tries to climb out of bed and can no longer remember how to walk because they have a gait apraxia, then you may choose to restrain them, not for convenience, but only in the evening to prevent them from climbing out of bed and hurting themselves. Determine the least restrictive alternative. Put the bed rail up first. If that doesn't work, then you can look at some other type of restraint. Make sure that your staff is trained on applying restraints appropriately. And most importantly, once you've applied the restraint, you need to go back and see whether or not it's effective. If the patient is still falling out of bed, because many of these patients are Houdinis that can get out of restraints, whether you have them restrained or not, then putting the restraint on isn't going to help them any. And always remember to monitor for side effects. No restraint is free of side effects, and your staff should know what they are and look for them. Likewise, you need to discontinue the restraint as early as possible. For instance, if you have a patient who went to the hospital to have their hip fixed, and now they're confused as a result of post-operative delirium, they shouldn't be restrained 4 months from now, but rather they should be, the restraint should be discontinued as early as possible, as early as they regain sufficient orientation to comply with their ambulation program. And lastly, you must have some sort of quality assurance program if you are in a facility. You must go back and retrospectively look at your restraint programs to see whether you are over-restraining and to make sure that patients are not being injured as a result of inappropriate use or inappropriate application of the restraints. What are some of the complications from restraints? This is something that's oftentimes overlooked. Well, first of all, think of what it would be like to be tied in a bed or tied in a chair for 6-8 hours at a time. That would be very uncomfortable for any of us. And just because you have dementia doesn't mean that you're any less uncomfortable than we would be. So first of all, what you see is you see increased patient discomfort. Secondly, patients can injure themselves while they are restrained. They can fall and they can get themselves hung up in a restraint. They can cut off the circulation to an extremity. They can limit their respiratory excursion if they're in a chest restraint and give themselves further worsening of their chronic lung disease. There are ways for patients to be injured in restraints, and staff needs to keep that in mind. Many patients become more agitated, not less agitated, in restraints. Most patients who are already elderly and frail, when you tie them in bed or tie them in a chair, will, within a fairly short period of time, begin to lose muscle bulk and coordination. So you can look for the restrained patient to have deterioration of their gait in a fairly short order. Likewise, restraint-related deaths account for 1 per 1,000 deaths in nursing homes. Restraint deaths are not uncommon at all. Half of the restraint deaths occur in bed, half of the restraint deaths occur while restrained in a chair. Demented, frail women are the most common individuals who die in restraints. And when you have a restraint-related injury or restraint-related death, you can count on a lawsuit. There are relatively few successful lawsuits for failure to restrain inadequately managed patients. Increased facility expenditure is a hidden drawback to restraints. Many nursing home operators think that you can save money by restraining patients. If you abide by federal guidelines for monitoring and release from restraints, it actually takes more manpower to restrain a patient than less. And so consequently, there is not a single study that indicates that restraints are either safer or more cost-effective than not restraining patients. In fact, studies clearly indicate that restraints are probably more expensive. Let's turn briefly to safety issues for home health workers and family caregivers, because much of what we've talked about today applies primarily for nursing homes and assisted living facilities. What are some of the safety issues that, for instance, a home health worker needs to be concerned about? Well, first of all, when you go into a home to sit for an Alzheimer patient, you need to get the firearms out of the house. Demented, confused patients may misidentify you as an intruder, or they may misidentify their own family members as intruders. Consequently, there should be no firearms within the reach of a patient with dementia. Likewise, dangerous instruments, knives, scissors, etc., should be locked away so demented patients cannot injure themselves or injure other people, such as the family caregiver or the home health aide. Dangerous equipment like stoves, chainsaws, power drills, etc., should be kept out of the reach of patients with Alzheimer's disease. You don't want them to injure themselves, and you don't want them to injure the staff that's caring for them in the home. Likewise, automobiles. Alzheimer patients rapidly lose the ability to drive. Most demented patients are unsafe behind the wheel. The family must come up with ways of convincing the Alzheimer patient to quit driving early in the disease. Likewise, that home health aide shouldn't be going out for rides with a demented patient behind the wheel. In the home, the same 5 issues apply for restlessness as elsewhere. When you are looking at that homebound elderly individual with dementia who seems restless, hostile, or agitated, ask yourself the question, are they afraid? Are they hungry? Are they simply tired? Are they frustrated with this terrible disease, or are they experiencing pain? You must always keep in mind that all of these symptoms, whether they be at home or in the institution, are a result of brain damage. On the next slide, we see sections from a mild, moderate, and severely demented individual. And you can see the progressive shrinkage of brain tissue, loss of brain cells, which underlies the progression of symptoms. It's also important to remember that as the disease progresses, behavioral symptoms change. Some very bothersome symptoms will eventually burn out, and the patient will no longer do those things that they did which were so disruptive in the past. Finally, when you're looking at a patient, whether they be at home or in a nursing home, remember this motto: snack them or nap them, don't zap them. Go for the behavioral interventions first before you reach for the medications.